All right, let's get started. Good afternoon, everyone. I'm Jen Chow. I'm Director of External Engagement at the Harvard Data Science Initiative, and thank you for joining us for today's industry seminar. We are delighted to have with us Cecilia Zenteno and Martin Copenhaver, from Massachusetts General Hospital, who are part of the team responsible for hospital capacity planning, including during this current pandemic. Cecilia Zenteno is the Data Analytics and Senior Manager in the Healthcare Systems Engineering Department at MGH. Her team partners with providers and administrators to develop and apply data-driven models to optimize patient care processes. Cecilia received her PhD in operations research from Columbia University and worked as a postdoc for the MGH-MIT collaboration for 2 years before joining MGH full-time in 2014. Martin is an operations research scientist at MGH. His research interests lie in the design and implementation of new healthcare systems with the use of tools from optimization and statistics. Martin received his PhD from MIT's Operations Research Center, where he was advised by Dimitris Bertsimas. And just a reminder that you can put in questions during their talk in the Zoom Q&A function or in the chat. And with that, I want to welcome Cecilia and Martin to take the floor.
Thank you, Jen, for the invitation. We're very happy and excited to be here. Let me just start my screen share. All right. Can everybody see the slides? Yes, I guess so. So even though it's only Martin and I presenting today, this is the work that we're gonna talk about has come through a very large team of doctors, administrators, and another data scientist, Michael Icu, who's been working really hard on making meaningful models for hospital capacity planning during this pandemic. So without further ado, let me motivate a bit why it's important to use data-driven models to make good decisions for the pandemic. So as we all know, throughout the pandemic, hospitals have faced multiple capacity management problems. You can imagine that during the first wave, the hospitals had to learn how to operationalize surge inpatient capacity without really knowing what they were facing. We knew that there was an epidemic going on in China. We knew that the European countries were being overwhelmed by a huge number of patients. But here in the US, hospitals really were a bit unsure about how it was gonna hit them, how hard and when it was gonna hit them. As we went through the surge and then the COVID census started to wind down, then the hospitals had also to figure out very quickly how to resume normal operations as quickly as possible. Because as you may have heard in the news, a lot of the hospitals had to suspend or postpone a lot of their surgical operations, which is a significant part of their revenue. And without being able to resume those in a quickly and steady, fast manner, that would compromise their financial situation significantly. And of course, now the talk of the last few weeks and what will be for sure the upcoming ones, unfortunately, is a second surge. How are hospitals preparing for this? How are they facing them? And how are things different from the first wave? This specific description, of course, applies to us, Boston. The hospitals in different areas of the country have experienced the pandemic in different timings in different ways, as you know. So just keep that in mind. We were thinking first wave, spring, second wave, basically right now. And so what I'm gonna talk about today is how we are using these data-driven models to ensure that the operational leaders at the hospitals can prepare for to have sufficient inpatient capacity as the COVID patients trickle in needing care. So just a bit of background about Mass General Hospital. We are MGH, as we call it. It's a large academic medical center here in Boston with over 1,000 licensed beds, out of which about 130 are for ICU or intensive care unit. the largest teaching, this is the largest teaching hospital of the Harvard Medical School, and it's integrated in a health system network that is currently known as Mass General Brigham, but previously it was also known as Partners Healthcare. So what the models that we're gonna show today, even though we're gonna show only NGH numbers, we also ran 4 or 5 acute hospitals within this health system network, and we also did some analysis for 3 community hospitals, which are distributed across Eastern Mass. To give you also an idea of how our team is embedded in the hospital structure and how our models inform decisions for hospital leaders, this is a simplified diagram of the leadership structure as the operational leadership structure for the pandemic. So we have the hospital incident command system, which is a very common structure that is used for emergency preparedness and disaster planning. And under that, there's a COVID Inpatient Operations Council that is in charge of managing how to take care of how many patients are coming in. Once they are staying here, how are they being taken care of in general care, in ICU, and then how we are preparing for their outflow. And our team, which is called Healthcare Systems Engineering, provides analytical support for all of those sub-teams as depending on their needs as they come up. And just before I continue, if you have any specific questions, if I start using too much lingo, please don't hesitate to ask in the chat. I'll do my best to answer them, or if not, Martin, feel free to interject and make sure that I'm speaking common language here. So for the rest of the talk, the way I'm gonna describe the comments or the timeline is based on how the epidemic has evolved in time. What you see here is the total COVID positive census or bed occupancy of patients at MGH in time. This is from our first admission in March 8th through November 30th, so this past Monday. And then that total census is broken down by general care census in red and blue in blue census in intensive care unit census in blue, sorry. Then we think of this whole time frame split into different phases. The first one is what we call the surge that goes from first admission through late May, when we knew that we were on a consistent downward trend and when the state government lifted restrictions for hospitals to be able to resume elective surgeries. Then the recovery period, which is when we basically started having to plan having everybody coming back in, all the elective activity that we had deferred because of the initial surge. Then we have a monitoring period where we knew that the activity had wound down, but we were preparing for what could be a very expected second wave in the fall and winter. And finally, the second surge. I'll be talking about the first surge, and then Martin will describe the modeling for the other phases. So let's think back in time and pretend that it's March 7th again. Then we started seeing our first admission at MGH. We hear about a few other cases being reported in the state, other hospitals starting getting their admissions as well. And everybody starts wondering, how quickly will our COVID-19 census grow? How many patients will need ICU level of care? As many of you may remember, there was a lot of talk in the news about patients needing ventilators. So when patients need ventilators or they are intubated, they need ICU level of care. So they need that equipment, and they need the staffing, and they need the ICU bed and the whole setup that goes around it. And then how large will the census peak be at general care and ICU level, and when will it happen? So basically, our team was called to try to make sense of all these questions, because with all the information that was floating around, we were just not sure what to expect. So let's review what we knew then. So I already described about Massachusetts. We knew about this Biogen conference as a potential super spreader event. So we knew there was definitely something that was gonna come to us. We also knew that in New York City, by then the hospitalizations were growing very, very quickly. They were probably 1 or 2 weeks ahead of us. And in some regions of Italy, especially in the north, in Lombardy, hospitals were really overwhelmed. Of course, doctors here have contacts all over the world, so it was easy for them to have conversations with them and get really scared as to what could happen to us here. So when we started trying to make sense out of this and started to answer the questions that I posed in the previous slide, the first thing that we started noticing after talking to a lot of epidemiologists and people expert in the matter, because we know data, but we do not know epidemiology, is that trying to predict the actual epidemiological curve is, of course, really, really hard. That was pretty evident from a lot of what you may have seen in the news, like the chart that I'm showing here. This is already sort of advanced in the first wave, but it shows the New York State coronavirus death projections from 5 different forecasts. So you can see how they can be completely off, and they have really wide confidence intervals. So and one of the main reasons why this happens is that there's very limited data to parameterize these models. Most of these are based on what epidemiologists call compartmental models. You have the disease is broken down in different stages, and then the population, like a small percentage of the population starts moving from one stage to the other. And the way you compute those values for those dynamics there's just a lot of uncertainty for a new pathogen, and it can vary very much from population to population. On top of that, there was also the unknown impact of the public health interventions. So how will those parameters be affected by a lockdown, by people wearing masks, social distancing? How much will people abide to those mandates if they exist at all? And how long will they take to take effect? And then, so even if you had some estimate of that, it was then very hard to think how we could translate those curves into what would be a single hospital experience. I think that the easiest way of thinking about this is, as you may remember, when we think of the US map and the coronavirus, it was really, really bad in the Northeast in the spring, and then things calmed down. Actually, first it was Washington State, then it was the Northeast, and then things started to move in the middle of the country. The South was very affected, then the Midwest, now things are coming back here. So I think that you can think of the same dynamics, but even just at a state level. The fact that you have like different clusters of disease happening in different parts of the state, it means that you're gonna have tides of patients coming into different hospitals in different areas at different points in time. So even if you have a very good model that has the epidemic pinned down projections for a state, then taking that and expecting that for a specific hospital, we know that that doesn't apply very well. So what did we do? So our modeling had basically 2 major components. The first one was, can we just come up very quickly with a set of scenarios of what the overall COVID hospital census at MGH and the hospitals at MGB, Mass General Brigham Health Network, will be like. And the other one is, once we start accumulating more data within our own hospital and we understand exactly how things are happening here, how can we make a good guess of where the hospital will be in the next 2 weeks? For the first part, like to understand the possible scenarios, we again talked to a lot of people, reviewed a lot of the models that were being released to the public, and the one that convinced us the most was this model developed by Dr. Nathaniel Hubbard and some of his colleagues at different universities at Cornell. and it's an Excel-based tool called COVID case calculator. And what they do is they basically try to approximate the curve of the epidemic with a gamma curve, which is like a very classic epidemiological model that fits data pretty well. And then try to fit that with the parameters that we knew at that point, like early March, of things that had happened. Things like the Princess cruise had some numbers coming from China, and other and the parameters were also coming from Europe, and then whatever they were seeing in New York, they were updating regularly. That helped. Then that was what's very cool about this model was that then they took the parameters of the CDC, the Center for Disease and Control Prevention, to understand out of those potential cases, how many of those are gonna need hospitalization, and how long are we projecting them to stay at the hospital needing general care and ICU care. And that generates like an expected hospital census. And for us, in terms of the microsite, then we were just basically counting patients every day and then seeing how we could best fit the curve that described the growth of our census. So let me just give you a little bit more of details of each one of these. So when we talk about the macro modeling approach, again, the goal is to understand what the magnitude of possible scenarios are going to be. So when we think of the inputs that we had to take into account to put into the model, this is a very basic diagram. First, we have to think of which are the possible people or patients that may come into the hospital. A very easy kind of first take about this was just take Eastern Mass and think of our MGH market share. Another way of computing this, for example, was just think about what is the percentage of ICU beds that MGH has in the region. And those are the ones that may determine also like how many patients may end up coming here, because they would basically run out everywhere else. And then you can start taking the CDC hospitalization ratios to see how many of them would get admitted, and then start making assumptions about how many of them would stay in gen care and ICU based on what New York was experiencing at that time. From those things, we ended up coming with two scenarios, what we call the mild and extreme. In the mild scenario, we were expecting, the mild scenario projected a peak number of daily admissions of 50 patients. So you can imagine 50 patients coming into your emergency department just with COVID, and another 10 requiring critical care. And the peak occupancy was projected to be 170 for general care and 100 for critical care. Here, I think it's worth thinking that our hospital has 130 ICU beds. So in a mild scenario, this was already like thinking that we had to either basically empty out almost all of our units of ICUs and just devote to COVID. Whereas the general care was much, much milder. And then the extreme scenario, which you can read the numbers here, that, you know, they seem sort of far-fetched, but we just didn't know what was going to happen. But why is this type of modeling important? Because this gave a lot of certainty to the staff and the operational leaders about what could hit us and when. And so even if these scenarios were not going to pan out exactly as they were projected, at least they gave them a sense of what they needed to do to prepare for each of one. And actually what we did was, let's take the extreme and see what is the infrastructure that we have to put together to be able to accommodate for this, even if it doesn't happen. Or an emergency preparedness lingo, prepare for the worst and hope for the best.
Cecilia,
yes.
I just wanted to pause and could you talk a little bit more about, someone was asking in the chat about how do you really study the mild versus the extreme scenario?
in the
what differs between those two and how are they created?
Yeah, very good question. So actually, maybe it's good if I show you a slide that actually has the parameters that define them. So the basic things that made the difference between the mild and severe were the case hospitalization ratios. There are so many parameters that go into this, right? So the first ones are the ones that describe the epidemic, which are like the attack rate and the symptomatic rate. We left those pretty much fixed because there was too much uncertainty around it. And then we played more with the case hospitalization ratios to understand what would be the kind of the things that we would see. And basically the difference in those percentages by different age groups are the ones that determine and their needs for ICU care are the ones that determine those curves. Did you estimate how many patients may get referred to MGH beyond normal? Yeah, so there's a question about whether we estimated how many patients may get referred to MGH beyond our traditional capacity. How? The question is with which data? It's a very good question. What we ended up doing is we did a lot of sensitivity analysis around our catchment population and these hospitalization ratios. And then we basically settled on these two mild and severe scenarios. Anything beyond the extreme or severe scenario that I already showed was almost something like unfeasible that we could have not, we would have worked through it, but it would have been harder to deal with, I think. So let me just go back to the slide where I was. Okay. Thank you, Martin, and feel free to interject at any point as well. So for the micro modeling approach, once we had this kind of big picture scenario, okay, so this is what we have to do in general. Basically we started tracking the COVID census for short-term predictions at our hospitals. And one thing that was particularly helpful was that on March 13th, there was an article published in the Lancet that they actually started fitting the Italy COVID census in the different regions. So the Dipartimento di Protezione Civile, or some of the government agency in Italy, has been very diligent, and since the end of February, they started publishing not only how many active positive cases the country has, but they also have the hospital census, which is definitely uncommon from the public sources that we've seen. And it's particularly useful because then you can start fitting curves on that and determine rates of growth. And it turned out that they were, in the initial weeks of the pandemic, growing at an exponential rate. And so we said, okay, so let's fit our data and see if that's the case for us as well. And the answer was yes. At least in the first couple of weeks, our total COVID census was growing at this exponential rate. And this is, and then we also compared it to what was the rate of two Italian regions. The first one was Lombardy, the one that you see at the top, RIT Lump, which, as you may recall, was the Italian region that was hardest hit by the pandemic in the spring. And we also compared it to another region called Veneto that was similar, at least in population size, to the state of Massachusetts, to get a sense of how we were doing. Fortunately for us, fitting the Italian hospital COVID census became a bit of a routine thing for us, and because they were ahead of us in time, we were able to see how their functional form for their hospital census was actually applicable to us very closely as well. This chart shows you the hospital census for different regions in Italy. Again, the green one is Lombardy, which was the hardest hit, and then some other regions that were not as badly hit, but definitely deeply affected. And in the end, this is basically what our projections started looking like at MGH. We had a first phase of exponential growth. Then we had a few weeks where the census was growing linearly. And then it became clear that at some point we were going to slow down. And we really wanted to get a sense of when the peak census was going to occur and at which magnitude. And at that point, Martin was very quick to fit a gamma curve on our census, which is what also worked for the Italian data. And that gave us the estimates of when we were going to see relief, so to speak. In terms of how those census curves compare with the actual Cornell model from the beginning, it turned out that we were very much in the middle between the mild and the severe scenarios. So the mild and severe scenarios are pictured here in like lighter colors for gen care and ICU care. And then the darker color lines are the projected moderate scenarios that kind of fit the best our data. And our data just updated halfway through April because this is just an incomplete chart that I have, but that's more or less how it played out. So I think it's remarkable that an Excel-based tool with, yes, a discrete event simulation incorporated into it was pretty good at least determining or approximating the dynamics of the COVID hospitalizations for this first wave. So what are the operational implications of all these models and how were people using the data that we were generating? So as I mentioned, the macro was very much for advanced planning, meaning that we needed to determine the infrastructure that we needed to set up to reach, if we reached any of those states. So when I say infrastructure, there are basically three pillars to that, which are bed capacity, staffing plans, and supplies and equipment. In terms of bed capacity, the first thing that you have to think of is like the beds. Where are we going to put in these patients? And basically, hospitals have two options. You either repurpose the existing beds that you already have. You can imagine MGH has 40-something units of general care that are devoted to different services. And COVID patients are taken care of mostly by general medicine doctors or patients. So can you start when the state said all elective surgeries need to be canceled or postponed, then you can imagine that a lot of those surgical units were going to have a much decreased census. And so how do you start choosing which units to start putting COVID patients into those? And if you run out of that space, what's next? So an example of that is the post-acute care unit, which is where patients recover and prepare for surgery. Those are not necessarily formal rooms with beds, but there are stretchers and there's space and there's staff that may be able to take care of these patients. In New York City, for example, the Columbia Hospital had to use operating rooms as rooms where you could put up to 4 patients. And so identifying which are your existing and potential surge spaces is a huge logistical endeavor that many people had to work through. And then on top of that, of course, is who's going to cover and take care of those patients in terms of attendings and nursing expertise. And with that comes projections for PPE needs and ventilators. I remember very clearly getting a phone call early March from supply chain, and they were wondering whether they needed to sign these super expensive contracts to buy PPE from abroad, because now everybody wanted that, of course. And they just, because it was so much more expensive, they really needed to understand how much more they were going to need. Like how much should we be signing these contracts for? Is it worth it? Are we really going to need them? And then, for example, the ventilators. How many ventilators do we have? It turns out that not every ventilator is a ventilator. There are some that are better than others. They need special supplies to operate, and they also need special staff. micro planning, our short-term projections or daily projections were used for were mainly to, once you have these plans from the macro and understand which units you're going to be opening next, the micro models or these daily short-term projections gave the operational leaders the information to understand when to trigger those new units. So this was very important because not all operational changes had to be made at once. There are definitely cases of hospitals that suddenly they just canceled all their surgeries and they just sat and wait for COVID patients to arrive. And either they either not arrive or not arrive in the numbers that they were expecting. And that's also a very high opportunity cost for hospitals. It's also very important for patient and staff safety. And finally, it also brought certainty and transparency to staff who were, as you can imagine, under a lot of stress. Other operational challenges that required some analysis were, for example, testing delays. So as you may remember, we didn't have good testing infrastructure throughout the first months of the pandemic. And so MGH and other hospitals at MGB had to develop their own testing capacity to help out with the volume. But still, the results were taking significantly amount of time to come in. And the operational implications of this is that you cannot just put COVID patients or patients that are waiting for a COVID test result anywhere in the hospital. Because if they are positive and you put them together with a patient that is COVID negative, you run, of course, the risk of infection. So even just learning where to put those patients in temporary units was an operational challenge. And that's very true for MGH, where 55% of our beds lie in semi-private rooms, meaning there's at least 2 beds in a single room. Then, of course, the impact of the deferred cases, what's going to be, how many beds become available in the moment in which we cancel the elective surgeries. Not every surgery can be postponed. So if I postpone those, estimating what census is going to kind of be relieved from our current occupancy, that gives you an idea of how many COVID patients you can accommodate in the short term. We were projecting needs for ventilators as well to see whether we needed to buy more ventilators or borrow them from other hospitals. Boston Children's was kind enough to lend us at least a couple of them. And then, of course, post-hospital care needs. We also had to estimate what the post-acute care census was going to be like, because once you discharge COVID patients, you need to make sure that the facilities like the nursing homes or long-term acute care facilities are able to care for this new volume of patients who also have different needs. So one example of that, for example, is here also. This is the number of closed beds by the average number of closed beds at MGH due to infectious diseases. In here in the top line is during COVID, and the bottom line, the dashed line, is before COVID. You can see the time range right there. So we had on average 50 beds closed just because of infectious control and problems. So you can imagine how that introduces a lot of additional operational challenges to any hospital. And with that, I'm gonna turn it to Martin, who will continue talking about the recovery period.
Perfect. Thank you, Cecilia. And just to answer one question that came up in the chat about PPE. Yes, we did actually work on that, and some of our colleagues in sterile processing worked to actually acquire technology to sterilize and then reuse various equipment, particularly masks, which were a rate limiting concern at that point. So yes, that's definitely something that was happening as well. So the modeling was, the goal, I think, was to really provide central awareness for everyone, and then the different aspects that Cecilia talked about, like staffing and operations and PPE. Each stakeholder in that area had insights into here is where we expect things might be going, and based on that, what level of need might we have. Okay, let me share my screen. Okay, perfect. So I'm going to continue on from where Cecilia left off, and that's really thinking about how do we transition from the previous period where we had relative, at the beginning at least of our first surge, had relatively little information about how it might evolve specifically for our hospital, although as Cecilia talked about, we did have that macro modeling that provided those insights. But once the recovery period had arrived, by then we had actually quite a bit more information. So actually by late May, we had on the order of 1,400 COVID positive patients who had been cared for at MGH by that time. So this is quite a lot of patients. And in other words, we have a lot of data on what kind of resources do these patients need? Do they need intensive care, general care? Do they switch between? Do they need a ventilator? How long are they in the hospital? What kind of needs do they have once they leave the hospital, as Cecilia talked about? And so in other words, we were much more poised than we were originally to actually create our own simulation model to understand how the hospital census might evolve going forward. And so that's exactly what we thought about doing. And we focused really on a few different key areas. And so this is just a real quick overview of the few that we were thinking about. And one of those is obviously the continued planning for COVID positive patients, which Cecilia has talked primarily about. But at the same time, we are a hospital that needs to continue caring for other patients who are critically ill and require a hospital level of care. And so we need to make sure we account for those patients as well. And Cecilia didn't talk about it, but we did also continue to very closely monitor that as well throughout the first surge period. But one thing that probably many people heard about, even in the popular media, but especially in medical journals and so on, there was a really significant drop off in hospital care for patients. And this is non-scheduled care, things like heart attacks and stroke and things of that nature, things that traditionally we wouldn't see decrease, but there was a lot of care that was being deferred by patients who perhaps didn't feel it was safe to go to the hospital. And that's a phenomenon that's been observed at this point across the entire world of deferred care that has taken place. And so by the time our recovery period started, when our census of COVID positive patients had started to decline, we were at 75% of our historical non-scheduled patient census. And so there still, now we expect those patients will start returning to the hospital. And we really do want them to come to the hospital. And so a lot of public awareness around that was happening at the same time. The last component to really think about here is also accommodating the return of elective surgical patients. And at that point, our inpatient census was at about 30% of its historical level. And just to comment, because elective is somewhat of a misnomer for those who don't work in healthcare. And elective doesn't mean probably what you think it means. Elective for us really just means we've scheduled it in advance, but elective can include a lot of things like cancer care, for example, hip repairs, and many other things that are not necessarily what, as humans, we might think of as elective, but at least for the hospital, we plan these. Due to guidance from the state, we had reduced a lot of our scheduled surgical patient care per the guidelines. And so we really need to think about how do we bring that back while we balance increases in our other non-scheduled patients, and also we still have COVID patients to take care of. And so the data that we used were these historical hospitalizations of COVID patients, and then for each of the other groups as well. And we had all of the data on length of stay, whether they need ICU, general care, and so on. And what we did is we produced reports 3 times a week, and we presented to the incident command system 3 times a week, trying to give a sense of a week out, what kind of census might we be expecting across these 3 primary groups. So the reason we tried to do a week out is a week gave us essentially sufficient lead time for adjusting the allocation of the beds in these surge spaces. And it also gave us time to think about how do we finalize procedural schedules if we need to call patients and confirm or cancel, and that would give us at least enough lead time for that kind of decision. Okay, so I'm going to go into each of these three groups just to mention this is really only a part of it. So there are other patient populations who were affected as well. For example, MGH takes care of pediatric patients, so patients who are younger, under the age of 18. We had made the decision to use pediatric beds to actually care for adult patients, given the increase in adult volume that we were anticipating. And so our pediatric patient population shifted to other hospitals in the region who agreed to take care of these patients. And so we really also had to think about how do we bring back our pediatric patients, for example. Okay, so the main group I'll talk about is for COVID patients, because that I think gives you a good sense of how the others work as well. And to simulate what the demand would look like at any point in time, you really need to think about two primary groups of patients. And the two groups are those who are currently hospitalized, and we would call these censored admissions. Really, censored here would be in the data science sense. So we know how long they've been here thus far, and we know what kind of resources they've needed while they have been here, but we don't know how long they will stay and what needs they will have before they stay. And then the other group of patients are our future COVID positive patients who will be admitted. We don't yet know who will be admitted, what types of patients they will be, but we know someone will be admitted. And so we have a different strategy for each of these groups. For the first group, we did kind of the very natural thing you might think about. We tried to match with historical hospitalization, so COVID positive patients, with a length of stay that was at least as long as the current length of stay I've seen for these patients, and also matching what kind of bed needs those patients had. Did they start out in the intensive care unit and then go to a general care unit, or did they start out in a general care unit and stay there their entire time, and so on. So that's how we thought about the first group, kind of a very classical simulation type model for that. The second group is harder because it hinges on estimating how do we think the daily new admissions of COVID positive patients will evolve. And so at that time, we did something very simple, and simple because really at this time, there was so much uncertainty about different moving parts that keeping our models as simple as possible was really a tremendously high priority, so that we could make sure that there was transparency into what we were doing. And at the end of the day, this modeling will be interrogated, rightfully so, by many different groups of people. And we want to make sure that we have faith that at least we're doing something that we can fully inspect and make sure that it seems correct. So at that point, we were actually using just basic linear regression on daily new admissions to project how will we expect the daily new admissions will look in the coming days. And since this time in May and June, we've definitely changed that to be quite a bit more sophisticated. But that's sort of the nature of how this pandemic evolved. As we got more and more information and had more and more experience with how the COVID experience was evolving internationally and locally, we were able to make these model adjustments with much more confidence. Just to also mention some other challenges for the more data-oriented folks here, there's a lot of issues if you followed at all in the media, which I'm pretty sure we all did. And that was about how patient care trajectories were changing. So early on in the pandemic, there was more use of ventilation. So having patients be mechanically ventilated, whereas the use of ventilators has declined for patients over time for a variety of reasons. And also the length of stay dynamics and other type dynamics have changed over time as well. So those lead to very natural questions about how do we actually perhaps change our sampling process and change the way we do matching to take into account these different strategies as well, all of which we've had to do. So there's two other remaining groups to talk about in this recovery period. One are for scheduled surgical patients, and the other one are for the non-scheduled COVID negative patients. Now, for those in the audience who, like myself, are interested in optimization, you could think very naturally about trying to make an optimization model to try to schedule surgical patients and bring back essentially resume operations that were ceased throughout the pandemic. We actually did not opt to do that, and I think there are a few different reasons. Whenever you have these kind of modeling challenges, you really have to balance the complexity of the model versus what the level of need is. And so what we did do, and this was led by a lot of our clinical colleagues, Wilton Levine in particular, he worked to create a clinical prioritization of different cases so that we could progressively bring back cases in a way that we started with the things that really needed to happen as soon as possible. And the latest ones to come back were those that had a lower level of clinical priority. And so then for us, what we did is we would actually take the surgical schedule for the next week as an input. We're not deciding that. And with that, we can run a simulation model, very similar to the COVID simulation, but now we're taking into account different patient types. So for example, we know a patient's scheduled to have a total hip replacement, and we know that they are having Dr. Smith as their surgeon. We actually understand how patients who have had that procedure with that surgeon before have needed hospitalization in the past, and so we can use that information. You could easily have thought about actually instead deciding exactly which procedures go in which order based on that clinical prioritization. We ultimately didn't choose that route because ultimately in this sense, the clinical prioritization is only part of it. There's a lot of other moving parts, and we really thought that an optimization model wouldn't have enough insight into the really nuanced dynamics at that point in time. The last group is non-scheduled, non-COVID patients, and this one had the least interesting modeling, but again, we tried to keep it simple when it could be. And if you look at actually what the census of this last group of patients looked like over time, here is in late February into early March. Our census tends to be quite high. We have 1,000 total beds, around 750 around on average of those patients are non-scheduled patients who have come in through the emergency department or who were transferred from other hospitals. This is what I had mentioned earlier, that we saw a really steep decline in this patient group throughout the early days of the pandemic, a kind of decline that we really otherwise would not have expected to see. And I think many people throughout the medical community were quite surprised to see that. But as we started to get closer to the recovery period, which ends when this graph cuts off, you can see that the growth is approximately linear, and linear is about the simplest model you can think of. If you wonder kind of why did it start to decline a little bit right beforehand, we always see patterns around holidays, and right then was the Memorial Day holiday, which usually changes census a little bit there. And so we did the simplest thing, and we did linear regression on that just by the past 2 weeks, and we used that to estimate the census of non-scheduled COVID negative patients. So let me give you, just like Cecilia talked about how the macro view performed, I'll give you a quick overview of how things look in terms of a few different error metrics that probably many of you are familiar with. And in particular, I'm trying to compare what we predicted for the census and what the actual census ended up being. And prediction is a good question. Like, am I talking about a point estimate? In this case, I am. Although actually what we ended up showing and what we still show to this day are not just a point estimate. We really also try to give a sense of variability. So because we're doing simulations, we have access to what, for example, is the 25th percentile of the census 7 days out versus the 75th percentile. And so we do have a sense of variability, which is not captured by this, just the point estimate metric, but at least this gives us a sense of how we did. Comparing across just a few standard measures, mean absolute error and mean absolute percentage error. The reason we did both is because some populations are much larger. And so for those, we expect that the percentage error would be lower. And for the other ones, we would expect it to be potentially higher. There's a great question in the chat about how did we actually think about updating these? And during the surge period, we updated these models on a daily basis, every weekday at least, Monday through Friday in the morning. In the recovery period, because there were a lot of different moving parts, we did continue to monitor this at a daily level, but we sent these projections out essentially once a week so that there was a weekly touch point to understand here is where we expect things to go within the next week. And so our projections are, at least the ones we're measuring here, the performance of, were each made a week at a time. So obviously we can do a much better job if we're only predicting 1 day out. So these estimates have both predictions 1 day out up to 7 days out. It's a great question. So just to give you a quick overview of what the results looked like, I think we were quite satisfied with the level of error that we had. And that's always the question in these kind of tasks, is what level of error is acceptable? And there's usually no great answer to that. But for example, in the COVID census, having a mean absolute error within about 6 patients for general care and 5 for ICU was really tolerable for us. In particular, because part of the planning is not just about how precise is our estimate, but also thinking about what direction is our estimate, right? Are we projecting increases or decreases? And that's not captured by those sort of metrics as well. Okay, so that's an overview of how the models look from a technical perspective. And I think it's important really to ground that in how they were really used. And our biggest use, both in the surge and in the recovery periods, was thinking about the timing and the order in which these different surge spaces could be returned to their pre-surge function. So as Cecilia referenced, we actually ended up having to change a variety of our general care floors. And so we had to convert certain general care floors into intensive care floors. And so we had to create new staff to work on those floors, new equipment had to be placed in those spaces, and so on. And so we had to think, when can we start to transition those back to what they used to be used for? Another area Cecilia mentioned were the post-anesthesia care units. And those are that are taking care of post-procedural surgical patients. Those spaces as well were converted to surge intensive care spaces. And so we had to think, if we have more surgical patients coming back, we have to actually make sure we have enough space for those patients too. And so just to give you a sense of how exactly that worked, once we started that recovery period right at the end of May, we started to, based on our projections, we saw that the COVID negative census was actually going to increase faster than the COVID positive census was going to decrease. And so in other words, we still needed actually relatively more capacity than at baseline. And so because of that, the incident commander decided to actually slow the closure of non-licensed spaces so that we still had extra capacity to take care of those patients. And eventually the pattern reversed. And so at some point, the COVID negative census actually slowed down in its increase, whereas the COVID positive census actually started to decrease more precipitously. And so we could actually at that point increase the pace of returning to the normal use of these spaces. Another point, which really it's hard to emphasize enough, is about how does this impact staffing? And so we have staff at MGH who were coming from also our ambulatory surgery centers, which were closed down. And so we had nursing staff from those centers taking care of patients on the main campus at MGH. And so as soon as we start to open up other locations, we have to think, how do we get those staff back and how do we really think about coordinating that? So now probably the question that's on everyone's mind is, how are we preparing for a second surge? And so there's a ton of planning, not only from a data perspective, but in particular from really an operations perspective of what will staffing look like this time around and what will the operating rooms look like? So I want to talk a little bit about one of the key inputs to the modeling, and focusing in particular on modeling for COVID positive patients, because by the time July had arrived, or the middle of July, we had resumed essentially regular operating room capacity, and other procedural areas had gone up to capacity. And so at that point, we were in sort of a maintenance phase. And so then the question really is, when do we start to have another surge? And so if you think about what this looks like, this is a plot of the daily new COVID admissions since the beginning of the pandemic, at least in Boston in March, up until where it is currently. And sorry, not currently, but this was right at the end of August, just so you have a sense. And this is what the plot looked like. And immediately when we had one day, which was August 3rd, we had 7 new patients admitted who were COVID positive. Now, depending on who you ask, 7 is a big or a not big number, but the question that we were very realistically faced with, is this a surge? And for some people that might seem silly to ask, but if you think about where we were at that point in time, there are two important things to remember. Our average daily new admissions at that point were actually around 3 patients a day, so it's roughly double that. Also, our experience in the first wave was that actually very quickly, we went from a small number to a much larger number, and then again to an even larger number with a roughly linear increase. And so it's not just a kind of silly observation. This is a serious question you have to think about answering. Is this a surge? And the way we thought about this were for a class of statistical models known as change point detection models, or CPD, as we have so lovingly been calling them now for quite a while. And change point detection models are suited exactly for this kind of task. Understanding, do we have a real shift in our data? So if I think about the distribution of daily new admissions, has the mean of that distribution changed significantly from one day to the next? And if it has, what is my new base state that I'm working with? This area, like many other areas of data science, there's a ton of models out there. And we are not experts in any of those models. And so really answering the call to action that many of us have faced in the pandemic, we learned everything we could about them, and we knew about kind of optimization versions of these, but not about the statistical ones. Some of the statistical ones, just to give you a sense, there are offline models versus online. Offline are not going to be great for what we're doing because we get data one day at a time, and we want to understand in an online fashion how things have changed. What we actually ended up going with were Bayesian models that have some sense of here's a probabilistic model for not just what distribution of daily new admissions do we have, but how likely are we to change from one day to the next. And that's actually what we ended up going with, is an online version of a Bayesian model that goes back to Adams and McKay in 2007. And I think one thing just to mention for those who are technical on this seminar, these were conversations that we ended up having with administrative and physician colleagues, many of whom don't have advanced statistical training. And therefore, kind of we have to make a value judgment of here are the kind of models that are out there, and really transparently presenting, here's the model we've chosen and why, and also being very upfront about why certain models aren't good, or why, for example, the model we chose, we know doesn't satisfy certain assumptions, but we have to choose something, and sort of we have to balance the different objectives that are out there. So just to give you a sense of how that approach performed, by that point in time, we were already using this, but just to show you what it looked like. At that point in time on August 3rd, per the change point models, we actually estimated there really hadn't been any change in our mean daily new admissions for actually about 2 months. And so even though there was that one day that was a high number of admissions, about 7, we still estimated that our mean was relatively low. And so it does seem silly, but this again provides very useful insight into what is the level of uncertainty we have with these models. And if we start to see a change in our daily new admissions, really what does that translate into? Now, to give you a sense, since I think hubris is probably worth thinking about throughout the entirety of the pandemic, we all have acknowledged that there's so much uncertainty, and we created this, well, we used this change point detection model specifically to protect ourselves against very steep changes in daily new admissions. So in particular, we wanted to make sure that we were always monitoring if there are these discrete jumps in daily new admissions that would be a very significant surge like the first one. The problem, as probably many of you are, it's not a problem, it's a good thing that we have not had larger growth, but our growth over the past few months has actually been much more gradual. And so at that, we have had to actually reassess which change point detection methods do we use and how do we actually present those to others. So in particular, some of these change point detection methods, like the one I talked about, tends to be a bit more conservative. And by that, I mean, it doesn't estimate a change unless there is quite a bit of evidence that there is a change, just very loosely speaking. The problem is that conservative approach, which was appropriate at the time, at that point, it became harder because our operational needs, we needed to really be able to detect smaller gradual changes. Cecilia has a great analogy, which is a common one, but thinking about the frog or the lobster in the pot, and the temperature slowly increasing, and eventually the lobster will not be alive. And it's an appropriate analogy, because if we're not also careful to small changes and paying attention to those, we can miss out on increases in census, which we really should be paying attention to. Okay, I'll finish by talking a little bit more about what's different in the second surge, just to give people a sense of how things are evolving. And there's been a lot of work to understand how things are going to happen in the second surge. One thing just to highlight, which I don't think there's enough discussion of, at least outside of the hospital, we certainly have this conversation many times, several times a day, usually at MGH. It's about how will we actually think about our system changing during the second wave. And so if we think back to what I talked about earlier, what Cecilia talked about, during the first surge period, our non-scheduled census decreased precipitously, and it went down to about 45% of its usual level. And those, as I talked about, there's a variety of reasons, but a lot of patients were deferring care that was needed, but they, for various reasons, chose not to seek care. So these are things like stroke and heart attack and things like that. So one thing is that we, especially as a hospital, have been making sure that a public message is, if you need care, seek care. And that's whether you have COVID or not. And so because of that, which definitely we should be doing, we don't expect that we would have anywhere near this level of decrease in the non-scheduled census of non-COVID patients like we did in the first time. So that has a lot of, it seems obvious, but then that has a lot of practical challenges, right? Because MGH, like many other hospitals throughout the US and the world, is on a typical basis quite full, or usually at or near full capacity. And so therefore, even a small change in COVID patient volume could actually have significant repercussions for our overall census and how we face capacity challenges as a system. So I think that's something to keep in mind as you think about how not only do the COVID positive hospitalizations change over time, but how do the non-COVID patients change? Do they stop coming to the hospital again? We hope not, certainly. Another part, just to finish, is we also have, I think, a much better sense of the possible interventions to this kind of event. And so, for example, if we think about surgical patients, in the first surge, the state government was much more proactive about a very large number of these scheduled surgical patients being deferred until a later period of time. Whereas now it seems there will likely be a bit more flexibility for us to manage internally about how do we use our available capacity to make sure that we balance the clinical needs of our different types of patients. And so now that we have a better sense of that, we can also think about other things. For example, how do we work as a system and how do we collaborate across our system as well? For example, how do we use our capacity in a pooled manner versus just as a single group of beds at one hospital? So those are some of the challenges that we are very actively thinking about, and I'm sure are on the minds of many of you as you follow the local and international news at this point. So now I'm going to hand it back over to Cecilia to just wrap up with a few thoughts, and then we're happy to take many questions.
Thank you, Martin. So just to wrap up, what we have described here is how with the advent of COVID, hospitals have really needed to balance the needs of multiple patient populations. Of course, it's very important to make space and make resources available for all the COVID patients, but we can't not forget about all the other patients who need urgent and very critical care as well. And balancing these two out is definitely something that hospital leaders have to take into account constantly. We used and applied multiple data-driven models, some of them really, really simple, and some of them much more sophisticated, depending on how much time we had to actually develop them, to be able to give some guidance to our leaders to be able to make the decisions that they had to make. And so just our quantitative approach was really critical to help them in understanding how much buffer capacity they had to have for urgent COVID and non-COVID hospitalizations, as well as guide them on how to return to the scheduled procedural volume, which was much, much harder than everybody expected. I remember all of us just hoping for the peak, and then we were gonna be able to relax, and it's not true. We had to work harder to make sure that the hospital could go back, be on its feet, and then prepare for a second wave on top of that. A lot of these analyses, which would have probably traditionally taken months, we had to do them sometimes within hours. I was thinking earlier today that maybe that's what it is to work in a startup. At MGH, things are much slower, as people who work in large academic medical centers may attest to. And being able to make the trade-off of how accurate and sophisticated do you want to be with something that needs to be done in the next few hours because they really need to decide whose surgeries are getting canceled, is I think it's humbling. And it also speaks to the how flexible we have to be as data scientists in understanding the impact of our work. And finally, of course, this is all great work technically, I think, but it would have not been possible without the help and the guidance of all our partners, doctors, clinicians, administrators, which are our best thermometer for how accurate our models are. So with that, we're happy to open it to questions, and thank you so much for joining.
Thanks, Cecilia. Thanks, Martin. While we wait for questions to come in, I have one, which is, have your inputs changed in the modeling for this current surge, knowing what we do now about, for example, treatment?
Yeah, so I'll start, and then Martin. Michael also does a lot of work on this, so I changed their names a lot. I think that one of the biggest things that has changed recently is the ICU utilization. Actually, just this morning, we were reviewing those numbers, and at least it looks like there's significant fewer patients need critical care. And if they do, they're staying shorter, which is good news. And on top of that, it seems that for those patients who use ICU and get discharged, all of this is COVID patients, of course, many fewer of them are requiring long-term acute care facility. And this is also a very important thing because there's a lot of capacity constraints around there. So knowing that patients don't need the services anymore is very comforting as we prepare for a second surge.
Yeah, that's a great point, Cecilia. And I think, there's a lot, if you read the medical literature, and even at this point in popular media, you see all of these studies about which drugs are working well and which aren't. And we haven't tried to proactively integrate any of those findings into our work. Instead, what we've done is, for example, in our simulation, we make sure when we're doing a matching, when we're trying to find a candidate patient to actually use to simulate a new patient, we sample more recent patients as opposed to patients earlier on in the pandemic. And that helps at least partially to, in a data-driven way, without saying anything about what therapeutics they might have been given, to understand that. It's obviously not a perfect workaround, and I think actually you could maybe think about how you would integrate that, but we haven't done that.
I'll take the next question, which is about which new data could be helpful to create better models in the future. So I think that that can be answered in two levels. At the hospital level, I think we just have the perennial problem of how our electronic medical records are being used. There's so much variability in processes, which determine then which data we get to use. That we had to do a lot of legwork and just to understand which data we could use. So it's probably not necessarily a new data point, but just acquiring and understanding which data you're using to create better, to create meaningful models is always takes way too much time. And at the macro level, I would say that it's pretty impressive how even now we don't have good understanding of how many hospitalized patients are even in the state Forget about the country. The way, and we've been in, at least, some of us have been involved in calls where these numbers are reported to the state, and we know our numbers and then how those get translated into the dashboards, the state dashboards, and they just don't make sense. They combine, they clearly do not understand our processes and the definitions of who is in which level of care and who's waiting for a COVID test and who actually has a COVID positive test. They tend to mix up a lot of things together, and so that renders their data pretty much useless. And so during these past few months, we've been asked multiple times, why are we using the Italian data so much? And the answer is because it works. It's one of the few countries that reports COVID hospital census. It's broken down by level of care, and it's reliable. So of course, there are a few mistakes here and there, but we just haven't seen that in the US. And even though we would have liked to use it, because of course, those would probably be closer to the dynamics that we experience here, we just couldn't find that. That's the first thing that comes to mind. Martin, do you have anything else?
I mean, I agree entirely. I think it's really amplifying a lot of basic problems that we have in day-to-day life. How do people define different groups of patients? And that can be hard on a very micro level, but especially if you think about how do we as a system define, or as a city, if I want to think collaboration across institutions, how do we define these things? It's very hard to get agreement and uniform reporting of these things. And I think understanding, and fortunately there is increased collaboration, but I really hope that this goes forward and that it's used.
So in terms of accessing the census data, at least for us at MGH, no, we already knew how to do that. Luckily, we have been using EPIC as our EMR for multiple years, so it was easy to, relatively easy to extend that to also other MGB hospitals. So that was not a big issue, I would say, Martin, right?
Yeah, I would agree.
Then have you solved the problem of how to find the number of elective surgeries that can be done given the constraints and COVID volume? That's an excellent question. I think that's a moving target, one that we are actually targeting this day, like today. Martin developed a very cool simulation that tells you what the projected census is given the current surgical schedule. And so I think it's hard to say how many elective surgeries you're going to have. You just, as Martin described very well, you have our medical directors determining what are the cases that really need to get done given clinical acuity. And then you just project the census and see how much you can accommodate from that and how much you have to cancel or defer, or try to probably reroute COVID volume somewhere else.
Yeah, and I would just add to that, I think there's a ton of great technical questions here about how could we do this. And 3 of us on our team have written our PhD thesis was in optimization. So we definitely would very happily try to apply something like that. I think for us, we know that the level of technical need, I don't think is there yet. And I think just understanding from a simulation perspective, given what we have now, here's how we expect the census to evolve. I think that relatively basic information is already quite informative. But there are definitely good questions to be asked about how could we actually optimize our schedule to fit inside our available capacity.
All right. Well, thanks, Cecilia and Martin, for a fascinating talk. And thanks to everyone for your questions today. This is the last industry seminar for this calendar year. We'll be posting next term's schedule soon. So please be on the lookout through our newsletter and website for upcoming announcements. And with that, I'm calling the session to a close. And thanks, everyone, and happy holidays.
Thank you, Jen.
Great. Thanks, Jen.